Colchicine is a widely used drug for treating gout, familial Mediterranean fever, Behçet disease, and pericarditis. However, it has also been found to be effective in preventing cardiovascular events. According to the 2024 recommendations of the European Society of Cardiology, a low dose of colchicine should be considered to reduce the risk of myocardial infarction, stroke, and the need for revascularization in patients with atherosclerotic coronary artery disease. Colchicine may also be considered for secondary prevention to reduce atherosclerotic cardiovascular disease in patients with chronic coronary disease, according to the 2023 guideline for managing patients with chronic coronary disease. So, what is the mechanism of colchicine's beneficial effects? Inflammation is an important factor in the development of atherosclerosis. Anti-inflammatory drugs may potentially have a beneficial effect on cardiovascular outcomes. Colchicine has anti-inflammatory properties that alter inflammatory cell-mediated chemotaxis and phagocytosis by inhibiting microtubule polymerization. Additionally, evidence suggests that colchicine reduces adhesion molecule expression and impacts cytokine production and inflammasome activation. Clinical trials showed that the recommended dosage of colchicine is 0.5 mg per day, taken orally. The first large-scale trial to estimate the beneficial effects of colchicine on cardiovascular outcomes was LODOCO. The results of this trial were published in 2012. Administering colchicine at a dose of 0.5 mg per day in addition to statins and other standard secondary prevention therapies appeared to be effective in preventing cardiovascular events in patients with stable coronary artery disease. Patients receiving colchicine were more likely to be free of the primary outcome. Additionally, there was a significant reduction in the incidence of acute coronary syndrome, as well as acute myocardial infarction and unstable angina unrelated to stent disease. The second trial studying efficacy and safety of low-dose colchicine after myocardial infarction was COLCIT. There was significantly lower rate of primary endpoint event in colchicine group. However, nausea and flatulence were more common in patients receiving colchicine than in those who took placebo. Also, patients in colchicine group had higher incidence of pneumonia. According to LODOCO 2 trial, the risk of cardiovascular events was significantly lower among those who received 0.5 mg of colchicine once daily than among those who received placebo. The rate of primary composite endpoint event of cardiovascular death, spontaneous myocardial infarction, ischemic stroke, or ischemia-driven coronary revascularization was lower in colchicine group. However, recent CLEAR trials showed that among patients who had myocardial infarction, treatment with colchicine, when started soon after myocardial infarction and continued for a median of 3 years, did not reduce the incidence of the composite primary outcome consisting of death from cardiovascular causes, recurrent myocardial infarction, stroke, or unplanned ischemia-driven coronary revascularization. Diarrhea occurred in a higher percentage of patients with colchicine than with placebo. Meta-analysis summarizing results of this study showed that colchicine at a dose of 0.5 mg was associated with reduction in MACE by 25%, reduction in myocardial infarction rate by 29%, ischemic stroke by 37%, urgent coronary revascularization by 33%. Colchicine blocks mitosis at the metaphase stage by disrupting the formation of spindle fibers. It inhibits cell division. Colchicine has a narrow therapeutic window. Common adverse effects include leukopenia, aplastic anemia, low platelet count, agranulocytosis, nausea, vomiting, stomach pain, increased transaminase levels, alopecia, muscle pain, and increased creatine kinase levels. Rarely, it can lead to neuropathy and kidney injury. Therefore, a complete blood count, as well as levels of alanine aminotransferase, aspartate aminotransferase, and serum creatinine, should be performed within 2 to 4 weeks of initiation and every 3 months for the first year. If stable, these tests should be performed every 6 to 12 months thereafter. If neuromuscular symptoms develop, the creatine kinase level should be checked. Drugs that may interact with colchicine in a clinically relevant way include verapamil, diltiazem, telmisartan, amiodarone, dronedarone, warfarin, protease inhibitors, antifungal agents, macrolides, ranolazine, and cyclosporin.
Thank you for watching this video. We hope you enjoyed it. If you want to see more of our videos, please subscribe and hit the like button.